questions as possible from the audience. And I'm going to start with the first one for Dr. Etzioni. So Dr. Etzioni mentioned that the concern with screening is that with the absence of screening is that we may start to see mortality rates. Guys, have a seat. We may start to see mortality rates increase by not screening. And she had a projection showing that that increase was possibly going to be substantial, 34,000 more deaths due to prostate cancer. So the question is, when will we have data that actually proves that will happen? When will we have data demonstrating that the death rate actually is going to increase due to a cessation of or a diminution of screening? When will we know that your projection is actually true?
Well, our projection was if we stop screening, everyone stops screening, and that clearly isn't happening. So
that projection was with no screening or just the current reduction in screening?
No, we didn't know what the current reduction of screening would be then.
Okay.
So we would recalculate the projection based on reductions in screening. It would not look exactly that way. It was kind of a worst case scenario.
So when would you imagine you'll have data to demonstrate that?
I think it takes a while for screening practices to translate into changes in mortality. So I wouldn't expect that we'd be able to see it empirically in the population within for at least several years. But I think that if we can get a better sense of how well screening works, which we're actually very actively doing, and trying to use the data from the trials in innovative ways to really get an insight into the true benefit of screening. I think that in a way is an indirect, an indirect outcome on the way to really seeing it in the population.
So as long as you've got the microphone, what are the new markers for PSA screening or just screening that you were alluding to?
Oh, okay. So we have a recent study of PCA3 that came out of the Early Detection Research Network. And there are markers that the Early Detection Research Network is working on beyond PCA3 and a marker also for TMPRSS2 ERG fusion that are both urinary markers. But those are the ones that we have been looking at, results published by the Early Detection Research Network on the diagnostic capabilities of those markers to identify prostate cancers, and we've been trying to translate those diagnostic properties into the impact on overdiagnosis and lives saved if we were to integrate those into screening practices.
Great. So we have two questions for Dr. Zhang about the spacer. A lot of excitement about that. The first is the spacer used with CyberKnife therapy?
So the FDA approval, the randomized trial that was done proving its efficacy, was done using regular kind of conventionally fractionated radiation treatment, so the daily treatments for 8 to 9 weeks. In reality, I think in medicine, there's going to be a lot of extrapolation. There's no particular reason why it would not also be beneficial for more hypofractionated treatments, meaning, fewer treatments like CyberKnife. So I don't know whether or not the various CyberKnife institutions are currently using it, but I think it's probably going to move in that direction.
And what about the bladder? Any influence on bladder toxicity with the spacer?
So unfortunately, it does not do anything to the bladder positioning. So there has been no difference in bladder toxicity. It is purely pushing the rectum away. So maybe at some point we'll see a different gel that can be injected to push the bladder further up from the prostate, but at the moment it has no impact on bladder function. Some
of you have a mic out there. I'll go for next question. Okay. So this is probably for Dr. Wright or Dr. Gore. Is finasteride of benefit for slowing or preventing prostate progression on active surveillance?
Well, there is for men on active surveillance, finasteride is a 5-alpha reductase inhibitor, also called Proscar, and its sister drug is dutasteride or Avodart, and there is a randomized study that for men on active surveillance randomized to dutasteride or placebo, and they underwent follow-up biopsies. And what they found in that study was that those men that were taking dutasteride were more likely not to have cancer found on their follow-up biopsy, with the idea being that it potentially is slowing or shrinking those not very aggressive prostate tumors. The caveat is that there are other studies using finasteride and dutasteride that show overall reduces the risk of prostate cancer by about 25%, but there may be it may allow for more aggressive tumors to develop. Both the studies, the earlier studies showed a little bit of an increase of higher grade tumors. So when I'm talking to patients on active surveillance, we go over kind of all these pros and cons of adding dutasteride. Some decide not to because of this potential risk of adverse tumors developing. I think if a man has a large prostate, because it shrinks the prostate, and they have a lot of urinary symptoms, that's a great avenue or a great scenario to add either dutasteride or finasteride.
So as long as you've got the mic, either you or Dr. Gore, can you discuss the new diagnostic options such as color Doppler ultrasound or maybe MRI?
So
that's a great question. Come on.
Yes, it is. There's a lot of exciting things trying to figure out better ways to do our sampling of prostate cancer in addition to the blood markers that we're trying to do. We're doing the MRIs in patients that have had a prior negative biopsy or been on active surveillance, and where it does help. It does identify lesions that we can't see on normal ultrasound, and then we can target those sites during the biopsy procedure. It still does miss some general cancers, so you still have to have the 12-core biopsy plus the targeted biopsies. It hasn't quite gotten to completely replace the standard biopsies. It also hasn't gotten to the point of just replacing biopsy altogether. Although it does seem to pick up more higher grade tumors, it does miss them as well. Color Doppler is another thing that's being, and there's microbubbles, different ways to, without using MRI, to just use the ultrasound to make us, help us see better. And those are all things of active research, all good things to talk about with your urologist if they have them available.
So for Dr. Zhang, this is an important question that may address a misconception. Isn't radiation treatment essentially playing whack-a-mole and not curative? So you might want to parse that question into treatment of localized disease versus treating metastases, right? Yeah.
So in prostate cancer, there has never been a successful randomized trial comparing different modalities of treatment for patients who have curable prostate cancer. So for example, comparing surgical removal of prostate cancer versus radiation. So instead, the data we have are large series published from various institutions that say, well, these are the 2,000 men who had surgery for prostate cancer versus these are the 2,000 men who had radiation or brachytherapy, et cetera. And from the results of those studies, the belief is that radiation is as curative for localized prostate cancer as surgery is. So I don't think it's whack-a-mole. It's more like nuclear bombing of the area, except it's slow nuclear bombing so that there's some survival of your normal prostate after radiation treatment. I think, as I said in one of my slides, the goal is to kill the cancer cells and leave some of the normal cells behind. So radiation is curative for a localized prostate cancer. It's not guaranteed, but that's the goal of the treatment. For patients who have metastatic prostate cancer, I think it sounds like from the agenda we get to hear a little bit more about surgery and radiation in patients who have oligometastatic prostate cancer. In that scenario, it is debatable whether it's curative or very aggressive palliation and control of cancer. So, but I would not describe it as whack.
So as long as you got the mic, do you have an opinion on the effectiveness of SBRT for reirradiation, and what are the risks?
Yeah, so that's a big question, and it depends on exactly what you're talking about. I think for radiation treatment, if you give enough radiation, you can kill anything. The goal is always to kill what you're aiming to kill and not cause too many side effects as a result of that treatment. And so I think for SBRT, it's a technology like any technology. I think we're excited about the ability to now more narrowly target smaller areas than we were before. but you still have to take it in the greater context of cancer treatment. So, for example, if a patient has, too many bone mets to count, for example, on imaging, there is probably not a benefit to doing SBRT to each and every one of those lesions. One, it's probably not safe, and two, that probably, even if we treated everything we can see, there will be more lesions that are too small to be seen currently that will develop in the future. So I think, there's technology, but there's always trying to take in the greater clinical picture. We are excited about doing re-radiation, but it is a lot about exactly what you're treating, what is the tolerance of the nearby normal organs for a second round of radiation, and what we think are the risks of treatment. And it's always a conversation about what we think the benefit is, and does that outweigh the possible risk of treatment. It's hard to answer in one summary statement.
So question for Dr. Stanford and probably crossing into Dr. Etzioni. What's the evidence for the role of family history in prostate cancer incidence? And related to that, what's the recommended screening for male relatives, young adult nephews, for example, of a man diagnosed with prostate cancer?
Great question. I didn't talk about genetics, which is one of my favorite topics as well. But we know from many, many studies, one of the most consistent things across the epidemiologic literature is that men with a family history of prostate cancer and a close relative, this would be what we call a first-degree relative, which would be a brother or father, have at least a twofold higher risk of developing prostate cancer themselves compared to a man in the general population without that family history. So there's no question that family history is a significant factor in increasing incidence of prostate cancer. Now, in terms of relatives and screening, the recommendation has always been that men who have a close family relative with prostate cancer are similar to African American men in having a higher risk, and that their screening should start sooner at a younger age than men without a family history. And I think historically both African Americans and men with family history have been recommended to start about age 40, but Ruth can update that.
So I think the question would be, so those are our recommendations, but the task force recommendations really didn't address risk as far as race or family history, and that's an important consideration. Right?
So the task force is mandated to really consider randomized trials, and there really aren't randomized trials of these subgroups. So our response to that is that we just have to understand the difference in risk and how it differs in these subgroups, and then we can develop recommendations based on this idea that we want everyone to have an equal opportunity to prevent an adverse outcome. And so qualitatively, it's clear that we should begin screening these groups earlier, and how much earlier really depends on the differential in risk, and whether we should be screening them more often also depends on the differential in the risk of progression, and we can learn that from accumulating data. So I think that going forward we will be able to counsel policy panels like the task force about these groups.
Dr. Zhang, does the SCCA offer CyberKnife? And if not, is it because of concerns with treatment risk?
So we do not have the machine called CyberKnife. We own a couple of its competitors called Synergy, so not nearly as successful at advertising as the CyberKnife company has been. Maybe my answer to that is we do not yet offer hypofractionated radiation treatment for prostate cancer, for localized prostate cancer, meaning we still have been doing the traditional 8 to 9 weeks of daily radiation treatment instead of offering 5 radiation treatments for prostate cancer. What we know is that in the field of radiation oncology, there's actually been multiple randomized trials testing the longer course of radiation against shorter courses of radiation. As few as 5, there's been tests against 12 fractions, 4-week radiation treatment. And what we know is that for each one of those clinical trials, when you do the radiation faster, you have a slightly higher risk of side effects. Now, these are all population-based numbers, meaning, right now as doctors, we're smart enough that if we take 100 patients, we can say, statistically speaking, this is what will happen to, this many of you. We are not yet smart enough to look at one individual patient and say, you will do better with this versus that. So what I typically tell patients about hypofractionated therapy is that if we treated 100 men with a, say, 5 radiation treatments versus the 8 weeks. Many of them, meaning greater than 90, will actually do quite well with one versus the other. A few patients will have more side effects with the faster course of radiation than the longer course of radiation. Multiple randomized trials have shown this. We are not smart enough to know who that few are. If you knew beforehand that, if I get CyberKnife, I will forever pee a couple more times at night compared to the longer radiation, you will probably choose to endure the longer treatment, just get the longer course of radiation. But most likely, statistically speaking, you'll be one of the lucky ones, 90, that will not have any difference in terms of outcome. And so we have tended to be more on the conservative side, and we have stuck with the longer treatment fractions. But it is something that's actively being debated in the radiation oncology community, which is, should we be moving nationally towards a faster course of radiation? Probably not the 5, other than for very select patients, but maybe more towards a 4 to 5 week regimen instead. And it's just all about, there's only, each patient is an individual. Either it's 100% or 0%, but as doctors, we're not smart enough yet to know that for individual patients.
Last question before the break, and then I encourage you to track these people down if we didn't get to your question. You know where to find them, right down here after the... So, Dr. Wright, have you looked at metformin and its effect on obesity and prostate cancer progression?
Yeah, we have quite a bit of interest in metformin as well, and we've done some research in that, and it is very exciting how metformin may have activity. When we were designing the study, the active surveillance one, we looked at both the lifestyle intervention versus metformin, because when the original diabetes prevention program study, and again, we're basing our intervention on that, they also randomized people to metformin to prevent diabetes. And the patients that had the lifestyle intervention lost the same amount of weight and were better at keeping it off at 10 years too, compared to the metformin. Metformin does have side effects too, rare side effects, but it does. And the AMP kinase I kind of mentioned up there in one passing slide for a benefit for cancer is activated through metformin. So a very interesting possibility there. So
great. So we're going to take a break. The restrooms are both to your right and to your left. Please come back in about 15 minutes, and thanks to the speakers.